Hello, I'm Omri Amsalem from Amsalem Medical. We are here today at the Assuta Medical Center, Tel Aviv, with one of the leading neuro and spine surgeons in Israel, Dr. Eli Ashkenazi. How are you today, doctor?
Fine, thank you.
As you probably know, one of the biggest challenges our patients face is making the right decision regarding choosing their surgeon. So my goal today would be to give our patients the opportunity to get to know you better and your work a little better. So if we can start with going back, if you can please share with us your career path, starting from medical school till today.
I graduated from the medical faculty in the Hebrew University at 1980. And then started my residency in Hadassah University Hospital in neurosurgery, and graduated at the early 90s. Did the fellowship in spine surgery in New York in Montefiore Medical Center, and came back, worked a few years as an attending neurosurgeon in the neurosurgery department in Hadassah. And the 2000 group, actually the spine unit of the Hadassah Hospital, we left and to open a private unit or private group practice in Assuta Medical Center. And since then, we're working here together. I'm a neurosurgeon, as you mentioned. The three others are orthopedic surgeons. And we're doing together all kinds of spine surgery, actually from the head to the tail.
If you don't mind, let's talk a little bit about your patients. Who are they? What kind of diagnosis you see in your daily routine? From what places in the world? I know they come from different nationalities, different places in the world.
We're taking care, actually, almost on all patients that are dealing, that have problem with spine. We're not dealing with very small children, but above the age of 5 or 6, we can deal with them routinely. So we see patients that suffers from degenerative problems, deformity, scoliosis, and stuff like that. Tumors, oncology patients that suffer from tumors to the spine column, not to the spinal cord. We also see trauma, not so much because this is a private facility, so we don't see a lot of trauma. We see trauma, but not acute trauma, but patients that are coming here to get secondary treatment after they had encountered trauma to their spine. What else? We're dealing here also with children with spasticity, doing what we call SDR. It's selective dorsal rhizotomy, cutting the sensory roots to release spasticity to children that suffers from cerebral palsy. I think this is about.
Patients are not only from Israel.
No, we have patients. Of course, the majority is from Israel, but we get patients from the Palestinian Authority. We have patients from Jordan. And we have also a big amount of patients coming from what was called the Soviet Union, Russia, yes. We also get some patients from Greece, from Cyprus, and from time to time also from Europe and also from the United States.
Continuing what you said about international patients, if you can please tell us a little bit about your experience with international patients, what mainly characterizes them?
Usually, I think we can divide it to three parts. The first one is diagnostic. The main of the patients, they come from incomplete diagnosis, and you have to complete the diagnosis and to decide if they really need surgery or what kind of surgery they need. The second part is patients that were treated, but the treatment was not sufficient, and you have to add. And the third one is complications, patients that had treatment, but the treatment was not good, and you have to try and fix what was done before.
So talking about diagnostic, as I understand, you see a problem in the imaging, in the approach to have the right, accurate diagnosis. So can you give us some examples?
I had a patient that came here that had a recommendation to have lumbar operation. And when he came here, I examined him, and his complaints were from the upper spine, from the thoracic spine. He had a lumbar MRI that was completely normal, and after we completed the imaging of his thoracic spine, we found that he had hemivertebra with deformity of his spine, and he needed a deformity operation of his thoracic spine. So this is one thing. The other is our patient that comes here with imaging that is not accurate or not good enough or not detailed. They come with MRIs that you can hardly give a diagnosis by what you see, because of the way that they perform this exam. So the quality of the exams are not sufficient.
Quality, you mean the number of slices, or using contrast material in some cases?
Mostly it's the number of slices. If you do an exam and you don't do enough slices, so they're too thick, so you don't get good information. And for MRI, it's very important, because MRI, not like CT, is doing an averaging of the slices. So they take like a few slices, and then the computer makes an averaging. And if you didn't do the slices, if you didn't do enough slices, and they're not thin enough, so the result that you get is not accurate, and you can sometimes miss the real diagnosis. And also I hardly see exams with contrast material. That sometimes is very important, especially with tumors or with reoperation. If you want to define, if you're talking about scar tissue, you need to have contrast material. And when you don't do it, so it gives you a very big problem to have a diagnosis and to decide what to do.
What would be your main advice, main tip for an international patient in former Soviet Union countries considering a treatment abroad?
I think that first of all, he has to have the imaging that he did over there to see initially if there is any slight of problem. I wouldn't come here without anything, but just to have a first impression. But then I think that a patient like this should come for two reasons. First of all, to get examined. I think that this is one of the important things, is to examine the patient and hear what his complaints are in order to decide what kind of treatment he needs. And then usually they need to complete the exams, sometime to do another MRI, sometime to do dynamic X-rays. A lot of places they don't do the simple things like flexion extension X-ray to see if there is stability or instability, or to do a whole spine to learn about the curves of the spine. These are things that are very important in spine surgery, and patients are not sent to do those kind of examination, and then it's very difficult to decide what kind of treatment you want to suggest them to do, or what kind of treatment is right for them. And this is one of the things that is very important in spine surgery, to give the patient the treatment that he needs, and not to give the patient the treatment that you know. So in order to give him a good solution, he needs to come to a place that can afford him the whole protocol of treatments, and to decide what treatment is right for him. Because we know in spine surgery that the best results is in the index, in the initial surgery. Then you can do revisions, you can try and fix things, but always the results will be inferior of doing a first good or correct procedure. If it's a complicated case, it can take a week. Usually it takes 2 or 3 days.
When you see a patient, can you share with us the approach of tailoring the treatment? I know that you see patients from different occupations, different ages, so I assume that you have some kind of methodology.
Of course, it has to do, first of all, with the patient itself. If it's an older patient, and not only a calendar age, but also a biological age. Some patients are 80-year-old, but they look like 60, and some are 50, then looks like 80. So you have to do the right procedure, and to take into consideration the bone quality, and of course the age of the patient, because a patient that is 60 and has at least 20, 25 more years to live, you'll offer him a different treatment than somebody that is 82 or somebody that is 20, even if it's the same problem. And of course, if the patient is a patient that is doing more activity and he wants to go back to this activity, so we'll try to tailor something for him that he will be able to go back and do what he wants to do, and maybe offer him a staged treatment. But you have to explain to him exactly. You have to tell them, look, I can offer you 1, 2, 3, and this will be the cost of doing a bigger operation, and this will be the cost of doing a smaller operation with the hazard. Maybe you'll need a revision in the future. But I think this is something that you have to discuss with the patient after you have all the material and you have all the facts, and then you can sit with him and tell him exactly what his status is and what you can offer him, and you can decide with the patient together what to do. I operated here patients that were dealing with professional sport, and also pilots from the Israeli army, that they need to be treated differently. When you flying a jet, you need to have a different treatment than when you're working in an office. And we can tailor the right procedure for everybody. And I know patients that went back after big surgeries to do professional judo or football or doing Ironman or stuff like that after they did surgery. Of course, it takes time, and it's a different time frame from everybody, but you can get them back to do almost whatever they want.
Being a part of a group practice, do you see advantages in that?
Yeah, of course. When you're part of a group practice, first of all, we offer the patients the ability to consult with more surgeons. So if I'm not sure about something, I can always have 3 more partners that I can consult with. The other thing is we have a routine neuroradiology meeting once a week with a neuroradiologist that comes here, and we sit on imaging, on difficult or problematic imaging. We have good relations with pain clinics, so we can refer patients to there. Sometimes they don't need surgery, but they need the treatment with pain clinics, so we have a pain clinic that we are cooperating with. Also with tumor cases, oncology, we're working with the oncology department and hematology department. So I think that, and the other thing is, if one of us has to go abroad or is sick or is going on vacation, there are always surgeons over here that can provide follow-up to patients after surgery or if they have any problems. We're doing about 550 cases a year, which is quite a load of I think we're one of the biggest units here in the country. And yeah, it works like a department. We have our own, all our patients are, when they're after surgery, they all lie in the same department. So we have there a staff of nurses that are doing whatever we want to, and they have our routines and everything. So it's very easy. And the treatment after surgery is very good, and you can rely on it. So, and we have also in the unit here, we have a nurse that is she's a coordinator. She takes care of the patients before surgery and after surgery, and we have a team of secretaries here. So because it's a group, everything is running, and for the patients, it's a very smooth procedure.
Talking about the procedures and unique technologies in your toolbox, can you share with us some interesting examples of those developments, technologies that you use in your procedures?
We have a few. Actually, all of them are Israeli developments. One of them is a procedure for deformity in young patients. Instead of doing a big scoliosis operation, which usually ends with a long fusion with something like 14, 16 screws in the back, there is a device now that you insert into the spine only with 2 screws. The ApiFix is a device that is good for treatment of scoliosis in young patients that has a flexible curve. So it has to be a curve above 40 degrees, and it has to be flexible in bending X-ray. It's a dynamic device that by teaching the patient a few simple maneuvers, they can actually, by doing those, straighten their scoliosis, because the device is dynamic, and by doing those procedures you can elongate the road inside and you can correct the scoliosis. The operation, instead of taking something like 5-6 hours, take less than 2 hours, and usually the patient stays at the hospital only for 2 nights, maximum 3 nights, instead of a week. Compared to a week, and the post-op course is much shorter. One other procedure is what we call TOPS. It's a total facet replacement. Patient that suffers from stenosis, instead of doing a fusion, you can do the decompression and then put in screws like you do in fusion, but instead of doing a rigid device, you put in a device that is dynamic and can move. So what it does, it can protect the disc above and reduce the chances of needing another procedure in the future. And also the post-operative course is much quicker. It's not good for every patient. You need to decide by the bone quality of the patient and the disc, because if the disc is already deteriorated and has loosened his height and is not functioning, so it won't help to put something that functions from the back. So you have to have at least more than 50% of the disc left, and maximum grade 1 of movement of spondylolisthesis, what we call. And so you can use this. We have other devices that we can use to give more safety and quicker operation and better results. This is another Israeli technology. You can see here it's a curved device with different angles that you can, and it's protected from one side, so you can put it actually inside the spine and take out bone without hurting the nerve tissue, because it's protected from this side. So it takes bone also only from one side. So you can use it to open the foramina of the nerves. You can use it to take out discs. And as you can see, you have different sizes and shapes. You can use it in the neck, this small one. You can use it for the neck. This is a bigger one. You can use it for the lumbar spine. This is also an Israeli startup that actually I'm involved in the development of this device. So we have here many new Israeli-made devices for spine surgery.
To end this wonderful talk, I would be happy if you can think about a story of an international patient you had that was remarkable for you in some way.
I have a few, but one of them is a young patient from Cyprus. He was 20-something, less than 30. He was supposed to get married in I think 2 months or something like that. He was working in a construction site and he fell from height. And he had a fracture of his low thoracic spine, and in the hospital there, they saw that he was paraplegic. He didn't move his legs, and they said that there is nothing to do. They contacted us, and because it was mentioned that he has sensation in his legs, and I saw the X-ray. We offered him surgery. He came here. He was operated. We did a decompression and fusion, and he's walking now. He needs a cane. He's limping on one leg, but he's walking. He got married and he's feeling fine. He came here for follow-up. He looks fine. X-ray looks fine, and he's happy. So I think it's very important that the patient will have or complicated patient will have consultation with physicians that know the field and know what to do and how to treat, and this is the best chances to get better.
Thank you very much for this wonderful talk. As I said, I'm sure that our patient now knows better who is Dr. Eli Ashkenazi, and thank you for sharing that with our patients from Amsalem Medical. Thank you very much.
Thank you.